Over to you, Madam Chair.
Thank you very much, Dr. Ong, for that interesting presentation. There are some questions that jump to mind immediately, but we'll deal with them towards the end of the evening.
All right, so you want me to continue with the...
Yes, please continue with the second part of the presentation. We have allocated 10 minutes for the second part.
Thank you. Please remind me if I'm over 10 minutes. I'm trying to
Yes.
within 10 minutes. So we're going to be looking at preventative strategies. This is the strategies to prevent cancers and focusing on not only, we're going to be focusing on lungs and stomach cancer, but we're going to be talking about general preventative measure for cancer. Now, there are different stages in terms of the natural history of the disease. At some point, we are going to be exposed to carcinogens, in this case, in the context of cancers, and we call stage of susceptibility. We are being exposed to carbon monoxide, we are being exposed to cigarette smokes and other chemicals and silicons and all of these. At that point in time, just to prevent the intervention can be implemented at that time is trying to change the lifestyle, especially modifying the risk factors. If you smoke, stop smoking, and so on and so forth, in terms of dietary practices and so on. That's what we call primary prevention. But another stage is, even though we try to avoid those risk factors and modifiable and non-modifiable risk factors, at some point, persons are going to have developed cancer. However, at that stage, the signs and symptoms of the cancer may not have established. So at that point, that stage we call pathologic changes. Changes is simply inside the body. But based on the notion that if we can detect cancers early, we get a more increase in terms of survival rate. So if we can detect even lungs and stomach cancer at early stage, we can improve the quality and in terms of lifespan. Therefore, we use screening in this stage, a secondary prevention by screening of the population or screening high-risk population, or sometimes we do opportunistic screening. The persons who is coming to our health facilities with other conditions, we grab and screen them. Now, some of us are going to be ended up having cancer, and cancer is going to be established. At that point, our focus is going to be on clinical management, including rehabilitative and palliative care. Using that concept, Jamaica has established a strategic and action plan. That goal of the plan is to reduce the burden and cost of preventable morbidity, disability, and avoidable premature mortality due to cancers by 25% by 2025. There are 6 priority areas that I'm going to be mentioning. Priority 1, which is the highest priority that we have put as priority 1, and we are focusing more on that as a nation. Reduce the incidence of preventable cancers through primary prevention and health promotion. Particularly looking at our modifiable risk factors, such as tobacco use and control, and harmful use of alcohol, physical activities, reduce level of sodium consumption, and reduce exposure to HPV virus, or in that case, or cervical cancer, and prevent exposure to occupational and environmental carcinogens and radiation. Again, I am repeating these slides just to remind our prevalence of obesity high in Westmoreland, the prevalence of smoking higher in Jamaica, and prevalence of smoking among youth, school children, and drug use and abuse in Westmoreland. Knowing those facts, what are we going to be doing it? So we're going to reduce the incidence of preventable cancers through primary prevention. One of the things that we successfully implemented in this country is that we have implemented the WHO, World Health Organization, WHO Framework Convention on Tobacco Control. So we have established a public space where no smoking signs, and we have put the legislation where it's going to be fine for those who breach selling those to tobacco and smoking in the public spaces. So legislation is to support this implementation. That's one of the things that we do as a primary prevention. It's also implemented the harmful use of alcohol, reduction in harmful use of alcohol. This is a part of our National Strategies and Action Plan for Prevention and Control of Non-Communicable Diseases. One of the success stories in this country is the, is the size, one of the non-modifiable risk factors causing cancers. And we have implemented what we call Jamaican moves in the country so that we can prevent the incidence of cancer. In terms of dietary practices, reduce the level of sodium consumption by way of food-based dietary guidelines established for Jamaica. In terms of carcinogen, exposure to asbestos as these are known risk factors for causing cancer, and we have established a national Natural Resources Conservation Authority, a guideline for management of asbestos. We are actively removing the asbestos from our old facility, renovating those facilities and so on. Those are being done as part of the primary prevention. Now, going to priority area number 2, which is screening and early detection. And these are the cancers that we have previously presented in previous days: cervical, prostate, and breast cancer, colorectal cancer. We have established the screening program for those. And these are the mobile units, private-public partnership, Jamaican Cancer Society, and our own Cornwall Regional Hospital. This is our government institution where screenings are offered. With respect to lung cancer, there's no national screening program or screening procedures for lung cancer in Jamaica at this point in time. However, the recommendation is for the low-dose CT scan for those who has history of exposure to tobacco smoke, but have no symptoms of cancer and who are between 55 and 80 years old. So that is being offered in the country for stomach cancer. And fortunately, there's no recommended screening test for spotting early gastric cancer in general population in this country. However, the upper endoscopy, using upper endoscopy to screen or detect for those with high risk for developing particularly stomach cancer, that is, they can be used as screening tool.
Dr. 2 minutes more, please. Thank you.
So priority area 3 for diagnosis and treatment. So we have established our cancer care center or diagnostic image center in the western region. It's located in Montego Bay, and using the high-tech technologies to support that. For priority number 4 is to improve the quality of life by way of providing palliative and rehabilitative care. And we also try to improve training of locals in terms of the oncologists, radiologists, and etc. is being offered to the local population. Priority number 6, we do the surveillance and research. The data that I'm trying to present, I presented previously, are using from our surveillance and research activities. So in terms of summary, Madam Chair, as population gets older, the chances of getting chronic non-communicable diseases, including cancer, is higher. Jamaican men and women have many known risk factors, both non-modifiable and modifiable factors. Summary 2, evidence suggests that low health-seeking behavior, especially men, in the context of lung and stomach cancers. So we have to do some targeted intervention in Westmoreland and in the national by extension. We also have a population which has knowledge and practice gap. So those who understand the importance of screening and importance of modifiable risk factors and so on, but still the practice is not following what they know. Health service providers such as doctors, nurses needs to actively engage in screening and encouraging persons to do screening. For summary 3, Jamaica has a plan to fight against cancers, despite the fact that we have challenges in technology and human resources. We need to make aware of our population about where these services are available, including referral system. So finally, we also need to look at the private-public partnership. It's just not, the government alone cannot do it, and private sector has some advantages in terms of screening and so on. So we have to use private sector as a private-public partnership. And also this session like this, we're going to be doing sensitizing our general population. Evidence still suggests that early detection can reduce the mortality and morbidity. And finally, it is very important that we have to practice personal responsibilities in this cancer care or prevention of cancers. We have to avoid risk factors. We need to do more exercise. We need to eat right. We don't need to abuse alcohol. If you are smoking, stop smoking and try to cut down the smoking, and visit your nearest health centers provider regularly for your checkup. And also, you need to encourage and motivate your loved ones to do so, your community and your nation. When we do that, when we all do that, you, your loved ones are going to be okay. Thank you so much for listening, Madam Chair, and everyone.
Thank you very much, Dr. Ang. The information that you have provided is essential to our understanding.
Sorry, Dr. Parker, we can't hear you.
Sorry about that. So I'm saying thank you very much. The information you have provided is essential to our understanding of disease progression within the communities and also the public's response to health messages. We are fortunate, and I know that each session could probably be extended for a whole session in its own. So I was apologizing in advance to other presenters for the time crunch that sometimes is there. We are fortunate leading on from that to have a volunteer who has experienced the effects of cancer in the family at a very close level in terms of a family member. We are joined by Mrs. Donna Parker, the spouse of Mr. Leroy Beale, who was diagnosed with colon cancer. And Mrs. Parker has agreed to speak to us today to share with us about her experience and some of the insights that she would like to pass on to the members of our viewing and our listening audience. Ms. Parker, welcome. Thank you very much for taking the time and agreeing to do this, to make your summary presentation. Go right ahead, Mrs. Parker. You can unmute your microphone.
Sorry. Yeah, thanks for having me. Where should I start? If I can recall clearly, it was I was overseas. Well, actually, it was in 2000 and I think it's 17. Yeah, I think it was in 2017. Yeah. Mr. B was at home. You know, one of the was there saying, "Boys, midsection is getting too big, so he's gonna do some crunches." Um, I think I fell asleep, leaving him in the living room, lying on the floor doing the crunches. I remember he said to me the following morning that you know, it looked like I pull a muscle or something in the lower section of his abdomen. I don't remember if it was the right side or the left side, his right or left side, going down into one of the legs there. So I said, you know, but I just laugh it off and saying that boy might be that push too hard or something like that, you know. I noticed that the pain seemed to be there after a couple of days or something like that, I think. And you know, to cut a long story short in that sense, we end up at his private doctor, you know, because the pain was just unbearable over I think it was a Saturday night or something there, but he bared the pain until probably I think it was a Monday or something like that, and went to the doctor and explained to the doctor. The doctor said to him that put him on the bed and you know, doing some touching and squeezing here and there, and I was saying to him it sound like his appendix, something to do with his appendix, and gonna go in. Yeah, went and did an ultrasound, and the technician told us the same thing. Went back to his doctor because he had to carry back the result to the doctor. Doctor sent him out, asked him which one of the hospitals he would want him to refer the letter to, and Mr. B chose up by UA. UC, sorry. And you know, when there I was they told him that when they did their tests and x-rays, CT scan, all the necessary, they saw a mass there, and that mass was covering the area, so they couldn't even tell, I think, if it was his appendix was acting up or whatever. But that mass, that is when I learned of this word, medical term, the omentum fat. And they were saying that that is like that fat is a kind of fat like a security guard that man the stomach area, and you know, and so forth, so forth, back and forth, back and forth. He was in the hospital for a couple of days. He came out. He was given Panadol. Panadol never helped because at one point in time he could not stand up in a straight position. He had back problems, so he had called on his private doctor. The private doctor said there was probably inflammation in the, you know, why that was happening. So he had advised him to take I think it was Advil, because Advil have an ingredient in there that fight inflammation. And he did, and a couple of days he was upright again. Fast forwarding to all was well for him. I think shortly thereafter, I think it was leading up to 2018 January, because we normally go celebrate the New Year either in church, or the coming in of the New Year in church, or we go watch the fireworks and all those things. But he wasn't feeling well. I think he went in. They held him. I think it was overnight or something like that, you know. So all those plans were cancelled and so forth. And I said he came out and all the necessary. Fast forwarding now, I went away in 2018. I came back in on the 1st of February 2019. All was well with him during all the year 2018. He said he did not get a outpatient date to have returned to the hospital and so forth. And so when I left in, I think the latter part of 2018, went overseas. I came back. I decided that I was coming back on the 1st of February. I think I was talking to him probably about a week leading up to that date. And he said to me, you know, funny enough, you know, I'm having this anxiety, like butterflies in his stomach. And he was saying to me, Lord, I wonder if he's gone, you're gone for such a while that I'm getting butterflies in my stomach hearing of you're coming home. So I laugh and say, really, after all these years, I still have that spark. You know, we'll just laugh it off. And I came back the 1st of February 2019, because that was the birth date day of our younger daughter. And I said I wanted to be here for her birthday. So I came back home. You know, I noticed his you know, like him saying wasn't like queasiness and all those things. I know that we on Valentine's Day we went and watched a play. The play in New Kingston there with Glenn Campbell and so forth. And you know, I noticed that he put you know, put out an extra effort to say that he wanted us to go together, myself, him, and our younger daughter, you know, but he wasn't wholesome in his stomach, he was saying. And going to the private doctor and everything, and first going down to we're doing checks, and the doctor was telling him that, I don't even remember what the doctor was telling him again, a private doctor, honestly. But I know that in Mother's Day, also Mother's Day, he wasn't, you know, it was like he was in and out. I think he was saying to me, because he had a huge midriff. It's like some people were saying that after the fact, some people were saying that, you know, they saw that he was like losing weight. I mean, I didn't take it for anything major because he was saying, boy, I'm a cut out rice out and that. He was you know, changing up his eating habits. So we just put it to say that, you know, those are the things why probably, you know, some noticeable weight loss and so forth. So I think in Mother's Day, yeah, we went out again and noticed that he wasn't eating as he used to, and just picking around, as they say, around the food. And as I say, we keep going to his private doctor, and the private doctor telling him stuff like that. Like, you know, it wasn't anything major and so forth till um the doctor, one at the time I said to the doctor, like put him, you know, make him lie down, because I keep saying to him, Mr. Bill, why is it when we go to the doctor just listen to what you say, probably take his pressure, you know, they put the thing around his arm and so forth, and then that's it. I said, but this doctor, and I put you up on the bed and you know, feel sorry my expression, feel you up and, you know, those things. So him say, all right then, when him go back to the next time, him go say that too, because like him is realizing now that, you know, rotted, yeah, you know, so and so. So him next time we went back, went up on the bed, and that is when now, when he was lying on, when he was on his back, and the doctor was touching his area, because I think they were saying that that omentum fat takes like about 3 to 6 months to move away from the area that that it is protecting and so forth. So when I'm saying, when I say, but why this thing here just stand up on you like that? What could be going on in that area that, you know, it's not reducing or anything, you know, and that is when now we start to push more on the doctor, and that's when the doctor was saying, boy, we're going to do CT scan and, you know, the whole 100 and so forth. And then we find out, I don't remember, you know, I don't know if June can cut in, because there's so many things as to why, what happened, why we end up back in the I know, yeah, we started we started, I don't remember if he I don't remember what happened, but I know that we were going back and forth in to the hospital as an outpatient, and when they're doing the check, they say we have to do checks. They were theorizing, it could be Crohn's disease, you know, all those things, and we end up talking to another doctor up there, not just the clinic dates, and that doctor was asking us, they asked us for the relevant signs based on what was happening to him. They did prostate checks on him. They were saying that the prostate check seemed to be okay. There wasn't any problem there. And I think in charts when they said he had to, a professor up there insisted that he had to do a colonoscopy, and that is when they said without that colonoscopy, then they will the doctor not going to do anything or whatever. But during all of that, Mr. B was going through severe abdomen pain. When I cannot I can't explain it because I haven't felt it. Felt it. I wasn't feeling it at that time. But him said the pain was excruciating, and but the doctors up there insisted that they can't do anything until they did the colonoscopy, and that is, I think, the doctors know when he went to to do the colonoscopy, they told him that they couldn't even no. Before we even reached there, another doctor who was up there that we were like, how I would put it, I would say you seen him like in a private space, And that doctor said he was Mr. Bill to go and do the bare enema or something like that word. And I think that is when we realized as a family now said, dang, something is really wrong, because when we went to do that test, as soon as the guy, the technician, put the thing entered from the anus, he said that there's a blockage. You know, within as he entered the thing there, he said, but wait, something is wrong, man. There's a blockage. And even we were saying, what did the council want back with money? Because where this technician a thing there. But you know, and it was so uncomfortable for Mr. Beal and so forth. You know, I wasn't in the room, but Mr. Beal was saying that because he thought he wasn't obeying what the technician was saying to him. So he was putting it to saying that the technician probably just said, sure, something, so a blockage is there and can't bother, you know, that way and so forth. But that is when we were saying, when we went back to the doctor said blockage and whatever. Yes. So we went, that is when we started taking things much more seriously, because we are saying if the guy enter and that happened, what, you know, what could be happening there. And is that time now when we went back to the clinic, the regular clinic, and that professor at the time was on duty, on call, said to us that we have to do a colonoscopy. And when we said, all right, we have to do it, he went in, he told the guy, the doctor who was gonna do the procedure, to tell him that he was in severe pain, you know, tenderness and everything, and so he must be careful. And as the guy, as the doctor do the procedure, because I was outside waiting. The doctor came out to me and said didn't even say anything to Mr. Beal as yet. But what he saw, he couldn't even go over to the other side where this supposedly mass, the momentum fat supposed to stand up and not reducing or anything. But as he entered, he saw signs of what looked like cancer, you know, and so we tell Mr. Beal, you know, inform Mr. Beal of it also, and so forth. So we went back again to the clinic date. At the time, the results never came in to say, yes, this is a fact, but I guess what the doctor saw, because he's the expert, we told him and everything, and you know, everybody started to put no move around or whatever, and told him that they can set up a date, and that's where the monetary part of it come in, and they set up the date and everything before the date of the operation. They told him that they had a meeting with him and telling that yes, they can go in and they can take it out based on what they see on the CD and the scans and everything and blah blah blah. Gave Mr. Beal hope, went and they did the operation. When he came out of the operating room, that is when he was learning now that they were shocked as to the size of the mask. So cancer was on that tight, so that is when they realized now that the tumor breached the corneal wall and was growing outside. So that mask that was on the opposite side of his midsection was what breached the corneal wall and was there growing. And they were saying that when they went in, they couldn't take it out. One, it was the size of a big breadfruit. Two, it started to entangle itself or whatever. It breached all the lining of each walls in your inside of you then, and was at the back there hidden and was growing. And that is when they stage it at a stage 3, and then I guess from there on, it has been downhill for us in the sense that Mr. Beal just lost weight, everything just 1, 2, 3, 1, 2, 3, 1, 2, 3. And I remember One night, Mama fell asleep because they put on the bag now to divert stuff to go into the bag because you know they didn't want anything more to be happening to the thing there. And I remember one night I only heard him calling out to me, and I jump out of my sleep and I say, yes, 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 Jay. And when I went into the bathroom, you know, just to see things gushing out from his near his navel area. I might say blood and all kind of stuff. And that is when we realize rush him off to the hospital. And
Donna, Miss Parker, I have a bit of a deal with June. You'll forgive me for intervening. I have a bit of we lived through a little bit with June um, in the QAU as we were coming down to this stage of his illness. And I know it has been heartbreaking for you, and it was so heartbreaking for June. Um, I'm not going to, unless you really insist, I'm not going to take you into that other piece because I know from June, I really know from June what that other piece is. Um, do you want to go on? June, is that you?
No, Katie, but yeah,
Yeah, right. So we will go. Mhm.
yeah.
We will go. We really want to thank you. Um, listeners and viewers, June is part of our Heart in the Quality Assurance Unit, and we really understand a little bit from the outside how much of a toll that it has taken on Donna, and the story goes down to that ending that she doesn't want. We're going to pick up with it a little bit more, Donna, with Dr. Harry, because I know the reason that you came here is that you wanted to make sure that any um, benefit that can accrue to anybody else based on the kind of experience that you have, that we can do that. So one of the things that Dorothy would have noted and that we want to do too is to go back to our professionals, um, our health professionals in the questioning section and talk a little bit more about the symptoms, because there's a lot you raise about misdiagnosis. There's a lot you raise about how you the efforts you put out, and it's not as though you're not making efforts and so I want to thank you. I want to ask you to hold a little bit more. We're going to hear some more and we're going to come back with the questions, because both Dorothy and I have been writing and making note of issues that you have raised in the context of having come here to help us help other people in spite of the circumstance. So I want to thank you very much and ask you just to hold on, just to hold on. Thank you for being so courageous with us. Thanks, really appreciate it. So ladies and gentlemen, you see, even by involvement with it, it is not an easy thing by any stretch of the imagination. And I started out by saying where life altering events are met with life changing research. And you just heard from Donna, certainly the epitome of life altering events. So we continue and we add more onto our knowledge, and then we come back with some questions that tie everything in as well. So coming next is Mrs. Asha Gay Thompson, who is looking at another area, part of what Donna would have mentioned and hinting to at part of Dr. Ng's presentation, which looked at what part does diet and nutrition play in prevention and treatment of chronic diseases. And but we know that there will be several such to mention. So I'm going to give you a very brief introduction for Dr. Thompson, for Mrs. Thompson, and she can fill in any additional information that she sees fit. Very passionate in terms of the promotion of healthy lifestyles. She began her undergraduate career at Northern Caribbean University in Mandeville, where she attained a BSc in dietetics and nutrition. Subsequently, she successfully completed postgraduate studies in an internship program, which qualified her to be a registered nutritionist and dietitian. She has a very great passion for the not only nutrition as an area of study, but nutrition as a life force and as a life-altering force. She's conducted and presented research on the topic, the association between dietary practices of Seventh-day Adventists aged 20 to 26 years old in the Savannah-Lamar district of churches and the prevalence of obesity, diabetes, and hypertension. She most recently completed her second research paper on the topic, barriers that affect the continuity of exclusive breastfeeding for 6 months among women in Elizabeth. I'm sure she wants me to mention that she has coupled her professional life with her ministry. She's a Seventh-day Adventist and a member of the Seventh-day Adventist Health Professionals Westmoreland Chapter. She's also an active member of the Jamaica Association of Professionals in Nutrition and Dietetics. She's a mother of 2 wonderful children, Zachary and Zania. I'm told the wife of a very handsome husband, tall, dark, and handsome, I heard, and that her real strength is in her very personable nature. She's very committed, her word is her bond, and she has a smile that helps to engage persons and therefore help them to listen a little bit closer to her message. So Mrs. Thompson, I invite you to make your presentation, and thank you.
Thank you, Dr. Thompson, for your introduction. Good evening, everyone. Are you able to see my screen clear?
Yes, thank you.
It's role in chronic diseases, prevention, and treatment. You're hearing me?
Yes, we're hearing you, thanks.
Okay, now when I saw this slide, it really brought my attention to what I needed to see. Every time you eat or drink, you're either feeding a disease or you're fighting it. So that meal that you had just now, which should have been quite possibly your last meal, was it feeding a disease or was it fighting a disease? Heather Morgan said it rightly when she penned those words. The presentation this evening, the outline, at the end of the presentation, you all should be able to discuss the global burden of chronic diseases. You should be able to identify how chronic diseases can be prevented by proper nutrition and lifestyle changes. And you should be able to identify recommendations for the prevention of obesity, diabetes, cardiovascular diseases, and cancer. Now, the global burden of disease is a project that was developed in 1990 by the World Health Organization. It's a comprehensive regional and global assessment of mortality and disability of a number of diseases and injuries, as well as the risk factors that cause these diseases. And it gives information on a global scale as to how these diseases actually affect a country. Now, chronic diseases are defined broadly as conditions that last for more than a year. So if you have a condition that lasts you for more than a year, it is considered a chronic disease. And then I'm going to be looking specifically at non-communicable diseases that are chronic. Now let's look on this web. When you look on this web, you're able to see the risk factors that will attribute to the final end with a diagnosis of one of these chronic diseases. And if you look specifically at diet, you'd realize that it is a risk factor for all of the diseases with the exception of lung disease, which Dr. Ong told us just now that if it is that you have lung cancer, your risk factor is the use of tobacco. Now, the lifestyle, no, the global burden data gave me this slide, and it speaks to the 4 major NCDs in Jamaica. And it indicates that actually 70% of these NCDs occur in Jamaica and they're responsible for death. So 21% is attributed from cancer death, 13% diabetes, and 33% for other circulatory system diseases that, could include cardiovascular diseases such as heart and hypertension diseases. Now, the top 5 leading causes of death in Jamaica from 1945 to 2004, this particular diagram, this chart, this table shows that there is a trend in the increases of diseases that are nutrition related. So in 1945, you had little to no nutrition related diseases. And then fast forward to 2004, you can see that diabetes, hypertensive, and the heart conditions that can be affected by our diet is on the rise. And this chart specifically encourages us to understand the risk factors that are related to most death and disability in Jamaica. And this source is from the Global Burden of Diseases website. And you can see the first highest three ranking disease risk factors attributed are in relation to diet. High fat plasma glucose, high fasting plasma glucose, a high body mass index, a high blood pressure. And then we see that the next 3 risk factors includes something that is related to our diet as well. So our diet and our nutrition actually has an impact on our health outcome. And the web again, just to remind you that out of the 4, this is how important our diet is to us. Out of the 4 chronic diseases that are listed here, diet is a risk factor of 3, and I think that is significant. So are chronic diseases preventable? Let's see. Now, it is encouraged that a timely risk assessment can minimize the risk of chronic diseases. So as Ms. Parker even mentioned, whenever the assessment is done, a thorough and timely risk assessment, it will determine whether or not you are at risk. And if you are at a higher risk, then action needs to be taken. To prevent a disease or to prevent anything, you need to know what caused it. Well, the causes of chronic diseases, as I already mentioned, there are additional causes. So there is underlying socioeconomic, cultural, political, and environmental determinants. And globalization has an impact, or urbanization and the population aging also has an impact. Now, there are common modifiable risk factors and there are non-modifiable risk factors. We can't have an impact. We can't change the non-modifiable risk factors, but we do have the ability to change the common modifiable risk factors. And we're going to be looking at obesity first. Obesity is now a global epidemic. I can imagine out of the 29 participants, which also includes me, how many of us, if we were to check our BMIs, how many of us would have been considered overweight or trending to overweight, obese, and trending to extremely obese? Now, these key findings I'm going to speak about are from the Jamaica Lifestyle Health Survey, and this was in 2017. Now, it indicates here that 577,300 Jamaicans are obese. Are you in that number? Well, 1 in 2 Jamaicans are considered. So that means 54% of that 577 indicates that 1 in 2. So every other Jamaican is considered to be obese. And we can see that the male and female distribution here indicates that 14.8% of our male population are obese. But then look at the female population, 41.2% of our females are obese. And that means we are at a higher risk, females are at a higher risk of these chronic diseases. And this is just showing you exactly where the BMI status indicates someone when it is calculated. And this is calculated based on their weight for height. Now, someone that has a BMI of less than 18.5 would be considered underweight. And then those trending up to 30 and then going over to 35 will be in the obese category. Now, in order for you to be considered healthy, you need to be within the 18 to 24.9, well, a normal BMI status, a healthy weight for your height. Now, this chart indicates that about 36% of our male population, this was in 2004, 36.2% of our male population have what we call android obesity or truncal obesity. And then we have a 34.1% of our female population having a gynoid obesity now this indicates that our female population has a high waist circumference. And if you have a high waist circumference, yes, women, your waist circumference being more than 88 centimeters or 35 inches, or for men more than 40 inches or 102 centimeters, you're at a high risk of having a non-communicable chronic disease, a higher risk. And this is true whether or not your BMI falls within the normal range, because excess fat around the midsection means that you're more than likely able to develop health problems because of the excess fat. This indicates the prevalence of obesity for the ages between the ages of 15 to 74 years for 2001, that's 3 years, 2001, 2008, 2017. And it shows that obesity is within 46.7% change. It has been increasing. Now, what are we expected to do to reduce this risk or to reduce our incidences or prevalences of obesity? This document shows us that it is very evidential, very convincing, this evidence. And as nutrition professionals, we do not promote information that does not come with evidence. We have to have some evidence as to what we're speaking from. And this is a convincing evidence to say that regular physical activity decreases your risk of obesity. And of course, on the other side, a sedentary lifestyle will increase your risk of having weight gain. Then, if you have a high dietary intake of non-starchy polysaccharides, dietary fiber, if you have a high intake of dietary fiber, your risk of having an increased body mass is further decreased. And if you have an increased intake of high energy foods, your fried foods, your sodas, those are high energy foods, you're at an increased risk of having weight gain. Now, there is some probable causes, and of course, the probable will become more convincing based on the fact that we're encouraging the Jamaica Moves initiative that our Minister of Health has indicated to be done in our homes and in our schools is going to be improving and providing a more convincing evidence that if there are changes in our environment, then you're going to have a reduced risk of weight gain. So if we're moving more, we're exercising more, if we are making the change as to our children not spending too much time on those devices and allowing them to go outside, spending more time to exercise, increasing physical activity, increasing the and helping the knowledge to be increased, the importance of physical activity, the importance of dietary fiber, or making healthy dietary choices, it will become a convincing evidence. And then breastfeeding. So if it is that we increase, pardon me?
2 minutes more, please. I was just giving you your time.
If it is
thank you.
Okay, thank you. Okay, thanks. So if we're increasing or we're having more breastfeeding in our population, then you'll find that that is a healthy start. That's the right start when we have infants getting the best milk in the correct proportions, right? And with all the macronutrients they need, that is improving the lifestyle from the start, from the beginning. So obesity in the developing world is seen as a result of a series of changes in diet, physical activity, health, and nutrition. And this we call a nutrition transition, right? And they're going to acquire more benefits, which includes the industrialized nations. So we're seeing that we're having more of those foreign restaurants coming into our population. The other day, Starbucks came here, so that's more high-calorie liquids, and it's just increasing. But as we gain knowledge, we understand the impact that nutrition actually plays on the development of chronic diseases. So I found this quite interesting. Hundreds of years of medical progress, all that I can tell you. I'm encouraging you to include physical activity and increase your intake of dietary fiber. Diabetes mellitus. The prevalence of diabetes mellitus in our population is at 1 in 8. So 1 in 8 Jamaicans have diabetes. That's a total of 236,000 Jamaicans who have diabetes. Now, how is it that we're going to impact diabetes, reduce the risk of having type 2 diabetes? Because we know type 1 diabetes is genetically inclined. But when you have type 2 diabetes, it's more lifestyle related. So how are we going to reduce your risk of having type 2 diabetes? We're going to try to maintain a BMI of 21 to 23. We're going to try to have some voluntary weight reduction, and that will come in effect with a change in your dietary intake, increase in physical activity, reducing your intake of saturated fats to 10%. And a dietitian and nutritionist can happily calculate that for you to determine what is the best and where you can get your best sources of the unsaturated fats. And then as it relates to fiber, you're going to increase your intake of fiber. So you're going to have whole grain cereals, legumes, fruits, and vegetables. And it's encouraged that you have a minimum of 20 grams of dietary fiber per day. And the evidence is here too. If you have voluntary weight loss and increased physical activity, then you're going to decrease your risk of type 2 diabetes. If you have an increased risk, you are at increased risk when you have overweight and obesity, abdominal obesity, physical inactivity, there you will have an increased risk of type 2 diabetes. And we are on to hypertension. 1 in 3 Jamaicans have hypertension. Every 3 persons in Jamaica has high blood pressure. 684,900 Jamaicans have hypertension. And then we have those who have pre-hypertension. So the dietary recommendation is the DASH diet. Dietary approaches to stop hypertension. And what does this entail? You are to include 68 servings of grains. So this is whole grains, cereals. Increase your intake of grains, high fiber, they are high in fiber. Then we look at 8 to 10 servings of fruits and vegetables and 2 to 3 servings of fat-free or low-fat milk, and that gives you your protein as well as your calcium. But when you have the practice of the DASH diet, it actually helps you to reduce your risk of obesity. So you're reducing obesity risk, you're reducing your high blood pressure risk when you make changes to your diet. And the evidence is there. It is convincing that if you have regular physical activity, you will decrease your risk. If you have fish and fish oils, vegetables and fruits, potassium, low to moderate alcohol intake, you would have a decreased risk of hypertension. And we're at cancers now. Now, a total of 40% of the cancer, of the deaths in the world in 2007 were related to, right? And Dr. Ong went of cancer causing the different types of cancers. He highlighted lung and stomach. You're seeing here that cancer 20%, prostate cancer 3% in men. Research it has
Miss Thompson, there's something off with the audio. We weren't hearing you.
I'm sorry about that. My internet connection went.
Okay.
Let me share the screen again.
Are you actually at the end?
Yes, I am wrapping up now. Right, so there's no evidence that relates to the dietary factors for which there is convincing for the increase in risk or overweight and obesity and a high consumption of alcoholic beverages. That is what is being indicated as your risk of having cancer, right? Now, and of course, of overweight and obesity increases your risk. If you have a high consumption of alcoholic beverages or alpha toxins are the toxins that comes from the fungi of cereals, corns. That is what you're to remove from your diet. It's not something that we practice, but if it is that person's who, you have to look on the mushrooms and so forth. Although mushrooms does has its place, but we have to really look on how it is that we're choosing our foods, because they might have some alpha toxins in them. Now, the evidence that convinces the reduced risks of cancer is physical activity for colon cancer. If you reduce your risk, if you increase your physical activity, you reduce your risk of having colon cancer. Then as it relates to stomach, dental, oral cavity cancers, there is a high probability that if you increase your intake of fruits and vegetables, then you will reduce your risk of these cancers. And of course, having your weights reduced within the normal body weight, the normal BMI. And then if you increase your intake of you have more than 400 grams of fruits and vegetables for the day, you reduce your risk of certain cancers. If you reduce your intake of salted fish and preserved foods and have salt in moderation, reduce your risk of that. It reduces your risk of certain cancers if you reduce your intake of those high salt foods. My references are here. But it's important to understand that how we choose our food, what we choose to eat, and how that will definitely affect our lifestyle. And our lifestyle practices will determine how we respond to the risks that might be modifiable and those that are non-modifiable, and or increased risk of having chronic diseases that we need to really celebrate health. It's all about what I put in, what I keep out, and how much I do. Physical activity is how much you do. Keep out the unhealthy foods and put in the healthy foods in their correct proportions, making sure that moderation is the key. Thank you. Over to you, Monica.
Thank you very much, Ms. Thompson. resonating your earliest statement as well. We're either harming our bodies or helping our bodies with everything that we eat. We will come back to issues there. So at this point, we've heard about, the last speaker spoke about nutrition and the kinds of things that affect our body and how that then leads to development of certain kinds of diseases. Very often we wonder at home, when should we leave to go to see the doctor? What is something that is actually concerning or an indication of illness? Dr. Harry is going to discuss with us when should a patient become concerned enough to seek medical attention for stomach cancer. Very timely and quite important. Dr. Milton Harry received his MBBS at
Okay, yeah.
Oh,
Okay, thanks.
it's gone again. Thank you. Dr. Milton Harry is going to discuss with us what should a patient be concerned enough to seek, when should a patient, be concerned enough to seek medical attention for stomach cancer. And that is critical because as we heard in areas of discussion before, and even as Donna spoke with us, we know that there are things that you are never even sure that these are areas that you need to pay close attention to. So Dr. Harry received his MBBS at UWI Mona in 2002 and later completed the DM General Surgery training in 2010 at the same institution. He did a fellowship in minimal invasive surgery and endoscopy at University of Toronto, Canada. He currently practices as a consultant general laparoscopic and endoscopic surgeon at Cornwall Regional Hospital and the Doctors Hospital, Montego Bay, Jamaica. He has a special interest in gastrointestinal cancer treatment. He is a husband and a father of 3 children. And Dr. Harry, we invite you to make your presentation of about 15 minutes and also to be ready to address some questions at the end. Thank you so much. Over to you, Dr. Harry.
Thanks for that introduction, Ms. Thompson. I'm just going to start sharing my screen here. All right, I'd like to thank Mrs. Sattrell and other leaders and organizers of from the MistyBlue Cancer Foundation for inviting me to speak about this rather important topic, stomach cancer.
Dr. Harry, could you go into presentation mode, which will increase the size on the screen? Right.
Is that good now?
We're still seeing it as with the slides lined up at the side. Okay, you go ahead. If we won't take up too much time there. It's just that it makes it much bigger on the screen.
Oh, I have it here as I don't know why it's projecting for you like that.
Okay.
But I'm in presentation mode here.
Oh, okay. You go ahead, please. Thank you.
Okay, so I'm looking at stomach cancer, specifically when should one become concerned. So over the next few minutes, I'll be looking at some incidences and risk factors associated with stomach cancers. Then we'll talk about some symptoms and we'll look at some investigations that we do for stomach cancer. And then I'll mention briefly various treatment modalities. So just a brief anatomy to take us back to our days in high school and university. The stomach is what we're looking at, and that's where we connect, the esophagus is connected to it.
Sorry, Dr. Harry. Is it only my screen, Dorothy, and the others? Right, it is now gone. Yes, go ahead. It is now changed. Go ahead.
What are you seeing now?
Yes, I'm now seeing the diagram indicating the stomach, the anatomy.
Is that in presentation mode or it's not?
No, it's still in the slide share lineup mode. You've clicked the little icon on the bottom of the screen.
Yeah, man, that's it. I'm there.
Okay. Yeah.
Or are you seeing it? Or are you seeing it now?
Well, I'm seeing it in the same way.
We're not seeing it in presentation mode. It's showing the list of slides to the left.
Right.
I don't know why it's doing that, because I'm in presentation mode at this point. I'm in the regular mode here.
Right.
Which mode are you seeing with that one?
We're seeing all the slides.
All the slides.
Right. So go over one more to your.
Which
right.
one? Which one are you?
Yes, that's it there.
You're seeing this one. Okay.
Yeah, that's it. There.
All right.
Yeah.
I was in the other one.
Right. Go ahead.
All right. Sorry about that.
No problem.
So yes. So we'll be looking at the stomach. So just a brief anatomy. When we eat, food gets through the esophagus and then to the stomach. When we're talking about gastric cancers, we divide them into proximal gastric cancers. Those are those that are closer to the esophagus, as well as distal gastric cancers. Gastric cancer was actually the leading cause of cancer deaths worldwide up to the 1980s, when this was overtaken by lung cancer that we'll also be looking at later on. The worldwide incidences has declined rapidly over a few years now. And this is due to recognition of various factors, including H. pylori, which we will talk about further on, as well as some dietary and environmental risk factors that were identified. Just a summary slide here, looking at world incidences, and this is from 2018. Dr. Ang had mentioned a lot of this. So what I just want to point out here is that stomach cancer contributed to about 5.7% of worldwide cancer. So it's still a significant cancer in today's society. Looking at the incidence here in Jamaica, right? It's actually the 4th commonest cancers in male, whereas it's the 9th commonest cancer for female, with incidences as mentioned here. And it's the 3rd commonest cause of cancer deaths in both men and the 4th commonest for women. And this is just showing you incidences across the world. And when you look at it, there are very high incidences in Eastern Asia, South America, and Eastern Europe. There are actually 2 subtypes of gastric cancers. There's the intestinal type and there's the diffuse type. The intestinal type of gastric cancer, this is the more common type, and that's the type that's common in males or older age group. It's also more prevalent in these high-risk areas. And this one is thought to be linked to a number of various environmental factors. The second type, the diffuse type, also known as the infiltrative type, this one is equally frequent in both males and females, and it's found more commonly in younger age group. I actually have treated a young patient. She was in her 20s, right? Not even 30 yet, when she presented with gastric cancer. And I brought that up just to mention it really associated with a bad prognosis. When she was diagnosed, it was at a late stage. We could not do anything surgically for her, and she succumbed to her condition. The diffuse type, there's no clear precancerous lesion that we identify for the diffuse type of gastric cancer. However, for the intestinal type of gastric cancers, there are precancerous lesions that can be identified, such as gastric atrophy and intestinal metaplasia. The core hypothesis postulate the progression for these intestinal type gastric cancer from chronic gastritis that progress to gastric atrophy, to intestinal metaplasia, then dysplasia, and then finally to cancer. So that's the progression. So there are precancerous lesions. So when you talk about gastric atrophy as well as intestinal metaplasia, these are things that we can pick up before, and we can do some intervention that we will talk about later on. There are about 2 patients in my practice now that had gastric atrophy as well as intestinal metaplasia, and they are on some medication to decrease the risk of progression to full-blown gastric cancer. So I move on to some risk factors. The 2 main risk factors for gastric cancers are Helicobacter pylori, commonly known as H. pylori, as well as a family history of stomach cancer. Did I say breast a while ago? Stomach cancer we're talking about here. H. pylori is a gram-negative bacteria that was discovered in the 1980s. It was about 1982 when Warren and Marshall discovered the link between H. pylori and gastric cancer. They actually got the Nobel Prize for Physiology and Medicine in 2005 because of this discovery. It's a good story to read, so you guys can Google it and have a look at it. These guys actually acted as guinea pig to discover this bacteria. In 1994, WHO, through its research cancer arm, they actually defined H. pylori as a carcinogen, meaning it's a cancer-forming bacteria. Just a brief thing about H. pylori. It can actually stay alive outside of the body in feces and in drinking water. How it's transmitted is not fully known, but the common knowledge is that it's either fecal-oral, meaning that we ingest it, or by oral, in that it can go through saliva as well. Those are the most likely routes for getting this bacteria. There are various tests that we can do to diagnose it. There's stool tests, there are urease breath tests, endoscopy, serology, as well as it can be cultured in the lab and it can be looked at under the microscope as well. There are various ways of detecting this bacteria. So as we mentioned, there are 2 important or 2 common risk factors, one being H. pylori, the second one being a family history. So even though most gastric cancers are sporadic, meaning that it will occur without a family history, there are approximately 10% of cases with a familial link, meaning you'll find that within the family. In only about 1 to 3% of cases, we'll detect a gene mutation. So there will be a genetic link to this cancer. Right? However, up to 10% of them, it will run in the family. So there are recommendations in terms of when to check the family to do genetic testing to pick up gene mutation. And the common mutation that we look for is the cadherin-1 mutation. So any family who have a family history of 2 gastric cancers at any age with at least 1 confirmed diffuse gastric cancer, they are at risk. So this is time to be concerned, and this is time to get to act on this problem. If there's diffuse gastric cancer diagnosed at age 40 or less than 40 or less, regardless of the family history, then that family should have some form of genetic testing done. And the third one, if there's a personal or family history of diffuse gastric cancer and this particular type of breast cancer known as lobular breast cancer, with at least 1 diagnosed in an age less than 50, then genetic screening should be done of the family members. Other risk factors include salt and salt-preserved foods. You know, in Jamaica here, we're accustomed to our saltfish, but salted fish and cured meat, these are risk factors. And these are borne out in a number of studies, including case control and cohort studies. Diets that are high in fried food and processed meats, this also increases the risk of gastric cancer. Obesity, you know, our dietitian mentioned a lot about obesity a while ago, and it is one of the risk factors. So once you're obese or overweight, then that increases the risk of gastric cancer. And the risk actually increases with the increase in obesity, right? So as your BMI increases, then the risk goes up. Smoking, tobacco smoking, increases the risk by about 1.5 times. And occupational exposures, such as those who work in rubber factories, those in heavy metal and coal factories, these also increase the risk. So all is not lost. There are also ways that we can protect ourselves from this. Again, the diet, we can either eat to stave off problems, or we can feed problems. So diet rich in fruits, vegetables, and fibers have been shown to reduce your risk of gastric cancers. And up to 40% reduced risk with fruits and 30% for vegetables. And just a point here to note that cooked vegetables do not offer the same protection as uncooked vegetables. So these studies are with uncooked vegetables. Refrigeration, right? During the invention of refrigerators, that was one of the big things that was shown to decrease the worldwide incidence of stomach cancer. Not only does it decrease the use of these salt-preserved food, but it also prevents healthier food. So less bacteria and fungally contaminated food can now be had. And it's also allowed for fresh foods and vegetables to be readily available for us to consume. Some statistics for us to bear in mind. Surgically curable early gastric cancers are usually asymptomatic, meaning we feel nothing at all. There's no problem that we're experiencing. And when you say early gastric cancers, I don't know if you see my pointer, but it's where it's just confined to the lining of the stomach, and those can be cured surgically. These are usually detected in countries where they have a screening program. And Dr. Ong had mentioned some countries that will do screening programs. These include those areas where the incidences of gastric cancers are very high. When you look at Jamaican incidence compared to incidences in these countries, it's actually 3 to 4 times above our incidences. So we in Jamaica, we don't have a screening program as our incidents are not that high. These screening tests are done at various intervals, and various tests are done in different countries. For example, in Japan, once you're 50 or older, you can either get a burial meal, or you can do an upper GI endoscopy every 2 years, 2 to 3 years. Whereas in Korea, they start at an earlier age. They start at age 40 and they go all the way up to 75. And they do not recommend burial meals. They go straight to an upper GI endoscopy, and that they recommend for every 2 years. More facts to bear in mind that in the United States, most symptomatic patients already have advanced, incurable disease at the time of presentation. So approximately 50% have disease that extend beyond the local area, beyond the stomach and the lymph nodes around the stomach. And of these patients, of these 50%, only half of them who appear to have this confined disease can undergo curative resection, meaning we can resect all the cancer cells and have no evidence of residual cancer.
Dr. Harry, I'm just giving you your 2-minute check.
2 minutes, okay. All right, I'll get there shortly there. All right, so the symptoms, when to be concerned. Weight loss and persistent abdominal pain are the most common symptoms of gastric cancer. And this is worldwide, and there are local studies that is in agreement with this. The weight loss is usually due to patient not eating as much. They feel nauseous because of the pain, or they eat and they feel full quickly. right? And sometimes they may have difficulty swallowing, difficulty eating, especially if it's in the upper part or the proximal part of the stomach, then they will have problems with dysphagia. So abdominal pain, this is usually a vague pain in the epigastric region or the upper abdomen, right over what we call the stomach. Right, well, patient will point to the upper abdomen and say, right over the stomach, doc. That's right where they have this pain. It's usually mild early in the disease, but becomes severe and constant as the disease progresses. We mentioned dysphagia, that's problem eating, right? So difficulty for the food to go down. Sometimes they will present with obstruction, right? So the food cannot pass the stomach, so they start vomiting. They might have early fatigue, so they feel they don't want to get up out of bed, they're lethargic, they just don't have the activity level as they usually have. And this is usually due to anemia, so the blood count is now low. So any symptoms like these, you definitely need to get it checked out. They might have what we call overt bleeding, so they vomit up blood or they pass it in the stool, where they pass this black tarry stool, that's Mellitus stool. And once you see that, you need to be checked out. Late disease present with problems like jaundice, they get spread to the liver, or they present with enlarged abdomen, so they have ascites, or they feel wax and cannon all over the body. So those are usually seen in late disease. Briefly, barium meal, you have to bear in mind that it has a high false negative rate. So up to 50% of cases are missed on barium meals. So the gold standard is to have an endoscopy done. So an upper GI endoscopy will pick up ulcers. If you're looking at the diagram here, the one on the top, that's a malignant ulcer, whereas in the one below, that's not cancerous. Or you can see frank cancers. So the growth, the big growth can be seen there at the time of endoscopy, and biopsies will be done then. After diagnosis is made, and you go on to do CT scans in order to help to stage a disease. You're looking for spread CTs of the chest as well as the abdomen, looking for spread. Various treatment modalities exist. So once the diagnosis is made, laparoscopy might be done. You might have chemotherapy, radiotherapy, and surgery. And the order varies. Sometimes you get chemotherapy, radiotherapy before surgery, or at times you'll have surgery before chemotherapy. So when to be concerned? One, when risk factors are present. If H. pylori infection is there, you need to get it sorted out if you're having symptoms. If you have a family history of stomach cancer, then you need to be concerned and get it checked out. Other risk factors, especially these modifiable risk factors, including obesity and smoking, these are things that we can work at. If symptoms present, so you start losing weight or you're having epigastric pain, especially if it's unrelenting pain, then you need to get it checked out. All right, so I welcome your questions later on, and I will hand over back to you now, Ms. Thompson.
Thank you very much, Dr. Harry. I've written out half a page, so there are certainly questions, and I know the members of the audience will have additional questions as well. We looked at stomach cancer and when to seek medical attention. We're shifting slightly over now to lung cancer. Dr. Mark Taylor says that lung cancer is the second cause of cancer death among Jamaican males. What are the associated causes, and how equipped is the National Health Service in effectively changing the landscape in the diagnosis and treatment of the disease? So, Dr. Taylor.
Hello, good evening.
Good evening. I'm going to give you a very brief introduction. You've sent me a few lines. Dr. Taylor is trained in cardiothoracic surgery and critical care surgery at institutions such as Harper Hospital and Wayne State University in Detroit, Michigan, USA, the Mayo and Cleveland clinics, as well as general surgery at Howard University Hospital in Washington, DC. He is a native of Jamaica who graduated from the University of the West Indies Medical School. As Chief of Cardiac Surgery in Oregon at Good Samaritan Hospital, Dr. Taylor received a 3-star rating for CABG outcomes from the Society of Thoracic Surgeons for coronary artery bypass grafting. Thank you, Dr. Taylor, for sharing as you will during your presentation. And please anticipate questions at the end.
Hello, good evening. I am going to give a very short talk on lung cancer as it this is my outlook or what I think about lung cancer here. I do have I function as I started a lung cancer screening program about probably about 10 years ago in Oregon, and we'll talk about that a little bit, but that's some insight. Can you see my slides? Hello?
Can't see them as yet. Have you shared screen? You've clicked on share screen at the bottom.
Yeah.
Green.
Yeah.
All right.
Let's make sure.
Yeah, just do it again.
Share.
Yes, something is coming now. Yes, there you have it. If you could just put it in presentation mode.
Okay. Okay. So there's a stark lesson in lung cancer. Lung cancer is deadly disease, higher mortality rate than breast cancer or prostate. It just kills more people once you have lung cancer. And Jamaica is a little bit different than the US, where lung cancer is very prevalent in the US. There have been a significant reduction in the incidence of lung cancer there, and we use that as a lesson here, and that has been a reduction in lung cancer in the US over the past 30 years, about 50%, and that's from smoking cessation. So it actually works. All right, so let's start with the slides. So I'm going to make this easy. I'll talk about the important things first and then go to the presentation. The most important thing in lung cancer today is, of course, prevention, and it's smoking cessation. There's nothing else to it in terms of the numbers. There are other important causes of lung cancer, and they're all environmental exposure, asbestos, silica, and environmental smoke exposure. But they're all, and in the US, they have radon in the basement, which has to be tested for in some houses. But that's it. Smoking causes lung cancer. From my experience, there is a small group of patients who get lung cancer. These are usually non-smoking females, and we're not quite sure where it comes from. There are two types of lung cancer. One is associated with smoking. In that group of cancers is called non-small cell lung cancer. It includes adenocarcinoma, squamous cell carcinoma. Particular squamous cell carcinoma is associated with smoking. If you look on lung cancer in the US and compare it to Japan, the survival rate for lung cancer in the US is about 30% at 5 years. In Japan, it's about 70%. They smoke heavily. They probably smoke the same cigarettes. The key is that in Japan, they have a screening program which detects lung cancer at an early age, and it's treatable. And the treatment is surgery. It's resected, and the 5-year survival for stage 1 is 70%. More advanced, the survival goes down significantly. So apart from prevention, treatment If you do not have a screening program, it's unlikely that you're going to detect lung cancer early enough to make it worthwhile treating, because when the patient presents with coughing up blood or hemoptysis or shortness of breath or lumps in the neck, it's gone. And we'll talk about that a little bit. Now, the recommendation for screening, there are different groups putting out a different recommendation. The important one on this list that I'm showing you is actually the U.S. Preventive Services task force, because they're the ones who make the recommendation to Medicare to pay for the screening. The others are all nice and good, but that's the one that comes up with the money. So generally, screen patients who are 55 to 80 and who have greater than 30 pack years off smoking. That's the high risk group. That is where is that is what is worthwhile screening. There are other high risk group, but that's the major part. And this is based on the study that came out, the National Lung Screening Trial, that was published in 2011, and they evaluate they studied 53,454 patients over a 6.5 year period, and they show that low intensity CT scan could pick up lung cancer at the early stage. This was compared to chest x-ray, but nothing else, because these cancers at this stage are completely asymptomatic. So the only way to detect them is to screen for them. Otherwise, they are incidental finding on someone who's having a CAT scan for another reason. The other big thing with lung cancer is video-assisted thoracoscopic surgery. Patients with a small stage 1 lung cancer can have that surgery and be home in a day or two. That is a big deal. The setup is costly, but in terms of hospital bed and ICU, it works out. The other important, or the other big deal in lung cancer more recently, is immunotherapy in patients who have more advanced or metastatic lung cancer. Optivo or the other immunotherapy treatment has advanced significantly. The base non-surgical treatment is radiotherapy for local control, and then chemotherapy, which is based on cisplatinum, platinum being the base for the chemotherapy. However, the survival with chemotherapy has always been marginal, and it certainly doesn't cure anybody, but it does reduce recurrence, particularly in patients who have resectable surgery. Immunotherapy is the new chemotherapy, but as you can see, I put the prices up there. It's pretty expensive. So, and I don't believe that immunotherapy actually cures anybody. It significantly increases survival, but the only thing that can cure lung cancer is to remove it, and the only time that can be done is when it's early. So, what I would recommend, since I have to address my what I'm supposed to speak about, is that Jamaica needs a screening program and a dedicated VATS, or video assisted thoracoscopic surgery program, which could be incorporated into what we have, what is available today. I don't think that we're going to be able to afford immunotherapy. Okay, so that's a high point. The rest that of what I'm going to say is pretty standard. Okay. Lung cancer is what we're talking about. Lung cancer, we're talking about primary, or it's not metastatic from another site. And we classify lung cancer into non-small cell and small cell. When we say lung cancer, we're generally talking about non-small cell lung cancer, because small cell lung cancer is more a systemic disease that only responds to chemotherapy. Well, it can only be treated with chemotherapy. So what we're talking about is technically non-small cell lung cancer, and that's the one that's associated with smoking and other environmental exposure. Smoking, and more smoking. That's what causes lung cancer. Okay, so sorry about the staging slides. Staging, stage one, when it's a tumor that's less than 3 centimeters in diameter and there's no other evidence of tumor. Stage one is curable. It's resected. Patient generally does not need any chemotherapy or immunotherapy or radiotherapy. The slides are not so good, but that is stage one. Then there is stage two, which is more advanced with local, usually with local nodes confined to that side where it is still resectable, but with chemo, the 5-year survival is about 50%. Stage 3 and 4, it's tough. There's one thing about stage 3 lung cancer where we commonly give chemo radiation to call neoadjuvant therapy to reduce the size and make it resectable. But even then,